Good afternoon, everyone. I would like to welcome you, all of you in this room and all of you online, to today's event on the role of the U.S. government in supply chain reliability. My name is Marta Wosińska, and I am a senior fellow in the Center on Health Policy at the Brookings Institution. We are gathered at the U.S. Pharmacopoeia headquarters, which is not a usual place for Brookings events, but a fitting one, given that USP is a 205-year-old nonprofit that sets standards for drug quality. And we will talk about some of the challenges around drug quality and their role in drug supply chain resilience and reliability. And so I am deeply appreciative to USP for hosting us here. I would like to begin with a story to help frame this event. It is a story about a mother who had to face one of the greatest fears of any parent. Her 9-year-old child was diagnosed with cancer. What doctors told her is that the most vital job as a parent was now to help her daughter stick to the drug regimen that was supposed to help her defeat cancer. So for several months, she and her husband turned their lives upside down to support their daughter through the challenges of grueling cancer treatments, as their daughter lost her hair, missed school, and missed her friends. Then one day, when they arrived at the hospital, doctors told them that their daughter's medication, a decades-old generic, was out of stock, and there was no alternative. That girl's missing cancer medicine was not an isolated incident. There are more than 100 drug shortages each year. They have included drugs like carboplatin and cisplatin, which are baseline chemotherapy drugs that are used each year by 500,000 cancer patients in the United States. Most of the drugs routinely stocked on crash carts to help EMT staff revive patients in trauma are in short supply. Shortages have affected such basics as antibiotics and saline. Shortages harm patients. Surgeries are postponed, treatments are delayed, drugs are substituted for less effective ones. Patients call around to find other providers who might have the drug available. And shortages confuse patients as they wonder, how? Why? I live in the United States, a country that is on the cutting edge of new treatments. This is the country of plenty. Why would an old, inexpensive, life-saving drug be so hard to find? During today's event, we will shed light on these questions. We have a group of experts who have deep commitment and deep expertise in why drug supply chains are not as reliable as we would like them to be. We will engage with this group not only to explain why shortages happen, but also what policies might help make the drug supply chain more reliable. With that, if I could invite panelists for panel one to please join me. Does this work now? Yes, it does. So to set the stage, I probably should have walked through the agenda. I wanted to tell you the story so much that I even forgot about the agenda for this meeting. In this first panel, we'll try to answer the question of why supply chains are not reliable, drug supply chains are not reliable, and for which drugs, and again, why. We will then have a session where we're going to take a deep dive into one shortage, recent shortage of saline, and what was the response and how stakeholders, including the federal government, came together to respond to that shortage. We will then have a panel about what's next and where we could go from here before we then conclude the event. So with that, let me introduce you to our panelists for this session. So going from my immediate left, I would like to introduce Christine Bader, who is the current president of Apotex USA, which is a top 5 generic drug supplier. She's the former head of Teva USA for generics and biosimilars, and former chair of AAM, which is a trade association for generic and biosimilar manufacturers. She has over 20 years of experience on generic and biosimilar leadership experience. Thank you for joining us. Sorry for stumbling here.
No, glad to be here, glad to be here.
Okay, next we have Alan Kokol, who is a pharmacist and Chief Government Affairs and Public Policy Officer for Civica, or otherwise known as Civica RX. I have known Alan for probably as long as I've worked on drug shortage issues, because he also has deep policy experience during his time at Pew Charitable Trusts, where he headed the healthcare group and has done a lot of work in this general area. So welcome. Thank you, Alan.
Be here.
And last but not least, we have USP's Vimla Raghavendran, who is the Vice President in USP's Digital and Innovation Division, where, among other things, she leads the Medicine Supply Map project. And if I can just add here, Vimla and her team have been great collaborators for me. And for example, sharing with me key data that if you have seen the tariffs paper that I recently put out, USP was a great contributor to it. So I really appreciate the collaboration, ongoing collaboration. So actually, Vimla, let me start with you, because of the medicine supply map, you have sort of the bigger picture on where around supply chains and where we have been doing shortages. You guys have put out, USP has put out a report on drug shortages. Could you tell us a little bit about, like, where is this happening and the insights from your work?
Yeah, no, absolutely. Thanks, Marta. So by way of background, and context, the Medicine Supply Map is a project. We started it several years ago here at USP. And we have two goals. So one is to map the pharmaceutical supply chain and figure out where the drug is made and its ingredients are made. And the second is to predict drug shortages. So we work with a lot of data, and my remarks are sort of based on what we are seeing in the data and in our attempts to predict drug shortages. So, as Marta said, drug shortages hit a 10-year high in 2023. There were 125 drug shortages. That number's come down slightly in 2024, but drug shortages are also extremely persistent. And so the average drug shortage lasts for over 4 years. That's a really long time. I just want to be very clear about what kinds of drugs we're talking about. Typically, these are older, generic, sterile injectables. Typically, these are not the drugs that patients are picking up at the pharmacy counter. These are used in hospital and clinic settings. They are not the drugs that you hear in the news, costing hundreds of thousands of dollars. These are often, sometimes cost pennies or, maybe a few dollars. So the question really becomes, why are these shortages so frequent and so persistent? The bottom line is it's a self-inflicted wound. And if there's one phrase I want you to take away from my remarks, it's bad economics, right, as a main driver of drug shortages. So, the most reliable predictors of drug shortages, we see 4 categories. So the first one is low prices. So as an example, 44% of the injectables that were in shortage in 2024 cost less than $5. Okay, so hold that number in your mind, because the second factor is manufacturing complexity. So the more complex a drug is to manufacture, the more likely it is to go into shortage. So again, taking that example of sterile injectables, these need to be made in very exacting conditions requiring high standards of sterility. In fact, USP set some of those standards, and they're critically important for patient safety. But that also makes them very expensive to make, right? So you have low prices, and then you have high cost of production, and so what we're talking about is very compressed margins. And so manufacturers then have very limited flexibility, and they respond by doing two things. So one is, we see concentrated production. So we'll see, a large proportion of the entire U.S. market share being made in one facility. And we saw that with some of the cancer drugs a couple of years ago. And so, you have this one single point of failure. So that's one. And then the second thing we see, and the FDA often points to this one, is underinvestment in quality management, quality systems. So yeah.
So you spoke about sort of the economics of it, but during the fireside chat, we're going to hear about a hurricane, right? So can you give us sort of a little bit of a context where that fits in the bigger picture? How much of it is driven by manufacturing quality issues and shutdowns in facilities versus other factors?
Yeah, so in the last few years, we have seen, some high impact natural disasters. However, I think you have to think about sort of, if a natural disaster were to impact, they're rare events, but if your margins are high enough, then, you would plan to have redundant capacity. What happens with these generic sterile injectable products is that because the margin is in there, the redundant capacity is in there. And so, when you have a natural disaster, the impact is, sort of the supply chain like breaks and doesn't bend, if you will. And so, it really goes back to this issue of bad economics.
Yeah, I was, everything she was saying, I was just wanting to jump in and say hallelujah. The fundamental underpinning is bad economics, right? And there's a whole host of reasons that play into that, including the model by which we sell drugs, the concentration of buyers, the increasing science, the increasing technology are opportunities, but again, you have to have money to invest in those opportunities as a private company. So if you don't have access to capital that looks like a smart business decision, you can't do some of those advanced technologies that would help bring down the cost and or add redundancy. Any economic model, redundancy is waste. I mean, really, that is what it is. So that's great. We can invest in that. We should invest in that. But in a system that only rewards cost of goods, and the lowest cost of goods is king, then that redundancy gets thrown out the window, as does, advanced technologies, higher quality systems are at risk. All of that stuff gets squeezed to the very max, and also results in a lot of offshoring. It's all very much tied together.
Well, can you dig into this a little bit more? So what encourages this level of price competition? What is driving the margins down to that extent? Why is it that price is the only thing that matters? If you could sort of help us understand that.
Yeah, so look, there are different issues in retail pharmacy than hospital pharmacy. So let's specifically talk with hospital pharmacy, because this is where we see maybe some of the most acute pain. Certainly not all the pain, but some of the most acute pain. Hospital pharmacies have complex economics. The reimbursement is a model that does not necessarily reset to current costs. So in pharmaceuticals, which is maybe the only industry that I can think of that has this, cost of manufacturing is supposed to go down and down and down and down and down and down and down. Never go up. Never have a cost of anything more than inflation. So raw materials has to stay flat. Cost of labor has to stay flat, which those things don't stay flat. On top of that, you have a whole reimbursement system around 340B, which is a safety net program for the hospitals, and a good program. Like we can certainly not debate the humanity of 340B, but it becomes an outsized participant in hospital sterile goods, and because in reality there is such a thing as inflation and costs of goods do go up, you get into a situation where you can get put in the penalty box with 340B and you sell your product for a penny. And if you sell your product for a penny on 340B, you then have to make up the profitability in the commercial market. And that economics often doesn't work and actually leads to a lot of manufacturers just exiting sterile manufacturing because they can't make it work. On top of the fact that in the commercial market in the United States, and I'm sure Alan can speak about this probably better than I can, but there is no concept of contract. You don't partner, you don't say, okay, you're gonna buy 10,000 units from me and it's gonna cost this amount of money. They'll say, we're gonna buy 10,000 units for you, you should plan on that. And then they'll call you next Tuesday and they'll go, now we have a lower price. And you either meet that price or the demand goes away. Meet the price, they'll call you the next Tuesday. So there's no concept of being able to plan for efficiency in production based on the way our medical system works.
So just to clarify, what you just described, is it in the retail setting or in the hospital setting?
Well, it's actually in both. So in the hospital setting, it's a little bit different in the sense that they'll bid. You know, you'll have large GPOs that will bid for business. But whether the hospital chooses to pull off of that GPO or if somebody else goes around the back of the GPO and offers a lower price, and then therefore they don't pull through the demand, happens all the time.
So you get committed as a manufacturer to a price, but there's no guaranteed volume. So it's
No
not the kind of usual contract that we think of, right?
Right.
I will buy this for this much from you for a certain amount. This is, if I buy from you, you will have to offer this price, but I don't commit to actually buying a certain amount.
No.
Okay. Okay.
I don't know if Alan has any.
So just sort of to rehash. So we have, I think one thing that we maybe haven't yet said is sort of the very basic idea of what a generic is, right? So a generic, the idea is that you have a product that's the same as the brand. And so when you approve a generic, it really shouldn't matter which one you take, right? And so because of this, all of our systems are sort of, you know, it really shouldn't matter which one you take. And so the only differentiating factor is price. And all of our reimbursement mechanisms seem to be sort of organized around this idea, and in a sense, sort of that's sort of underpinning the.
And what's missing in that equation for this discussion is, you know, product A may cost 5 cents more than product B, but product A from manufacturer A has a higher predictability of supply. They've had long-term positive inspections with the FDA. They've invested in redundancy. They have a different inventory strategy as far as, you know, how many weeks of supply they keep in their warehouse. None of that gets considered. None of that gets considered in general. You know, there's models where people are trying to shift that, so you can actually make an informed decision when you pick product A. It comes with all of these additional attributes. But our reimbursement system doesn't pull that through. So even if you can get a hospital system to sign up for that and say, no, we will pay an extra 5 cents per vial for this life-saving medication, which is kind of a crazy statement, but that's really what we're talking about, 5 cents a vial. There's no guarantee that the reimbursement model that's in play will do anything for that hospital system. So there has to be a comprehensive look at how all of these policies sit together to incentivize the behaviors and the redundancy that I think that we're all looking for.
So this is actually a great segue to switch to Alan. Alan, can you tell us about Civica and why Civica came into existence and how you have been trying to sort of reimagine the way this market works?
Thank you. So I absolutely endorse everything that's been said. The first point I always make when talking to people about drug shortages is I remember back in 2011 when shortages first spiked, and if you ask experts what was going on, at the time, you know, a couple of plants had shut down, one of them permanently, and one of them temporarily, and there was a big spike, and the word you would hear is it was a perfect storm. And 14 years on, I think the most important thing to recognize is this is not a perfect storm. This is an output of the current system of the way we buy and consequently manufacture generic drugs. So about 6 years ago, a group of health systems had that recognition, and they said, clearly this market's not self-correcting. If we want a different outcome, we've got to have a different business model. And so they created Civica as a nonprofit generic drug company with a mission around preventing and mitigating shortages. And I always say that being a nonprofit is probably the least important part of our model. But what we've done is created a company that tries to go at sort of each of these weaknesses that we've identified. So every drug that we bring to market has been chosen by the health systems because they're in shortage or at risk of being in shortage. Vimla identified a number of factors. The strongest predictor of a future shortage is the past shortage. If we could solve for drugs that have been in shortage in the past 10 years, we'd solve most of the shortage problem. Not that there wouldn't be additional ones. So we choose those products, and then we enter long-term purchase agreements with the hospitals, or the hospitals enter long-term purchase agreements with us. Guaranteed volume, take-or-pay contracts. So it's the kind of contract that doesn't really exist elsewhere in the generic drug supply chain. That does a couple of things. It brings stability into the market. It lets us know, lets our suppliers know that they will have a certain volume for a certain number of years. So that brings stability back. We also enter those agreements directly with hospitals. So we're taking out some of the big aggregators of purchasing that are driving price down without giving any kind of guaranteed volume. The other thing we know is that production of drugs is inelastic. Once a shortage starts, as Vimla has said, it takes a long time for the market to respond and produce drugs. Because Civica has that predictable demand, we can actually sit on a buffer inventory. So we target about 6 months for every drug. So why does buffer inventory matter? So two things. Obviously, a 6-month buffer inventory doesn't get you through a 2-year shortage. But it can give you time to order additional batches once that shortage has started, or produce additional batches. But the other thing it can do, and this is a big thing we see in a lot of shortages, Laura has talked about this a lot, is you get hoarding and anticipatory buying, and you may actually not have a shortage of inventory in the system. And so if there's a buffer inventory, at least in theory, if we get this to scale, then everybody kind of calms down and knows, no, I've got 6 months of drug dedicated for my needs sitting in a warehouse. I don't have to be buying right now. So that's part of the concept behind buffer inventory. And then we have a strong focus on US manufacturing. Our second tier is to go to Canada or the EU. We go to carefully selected partners in other parts of the world. We try to avoid China, and that's driven by wanting to operate in a highly regulated market where the regulatory inspectors are there frequently, and by having confidence that we can oversee quality. We actually go out to our suppliers before we contract. We audit them, we see their facilities, and we release drugs, after reviewing GMP records on a batch-by-batch basis. It's important to talk about quality just quickly, and then I promise I'll stop. When we say the word quality, I think people often think, does that mean drug A is less effective than drug B on a given day? But what we're really talking about in the drug shortage context is, are we choosing manufacturers that are less likely to fail in future, that they have what FDA calls quality maturity, that they have robust systems in place that mean they're not going to have the quality problem that's often the proximal cause of a drug shortage. And by the way, having those quality systems in place and investing in new equipment, that costs money. And so poor quality drives out good quality in the pharmaceutical supply chain. So as long as the market keeps valuing price over everything else, we're going to have those shortages.
So I've got to ask Christine, and then I'll come back to you, Alan, in a second. And in a sense, maybe those are tied together, those two questions. So why can't Apotex do something like this, offer long-term contracts to hospitals? And
we can. What we don't see is the commitment, right? I think what's unique about the Civica RX model is that They were very motivated hospitals with a set of very common concerns. What you see at scale is that hospitals, like many parts of the healthcare system, are under financial pressure. And it's a good idea until the budget comes. And then something's got to get cut. And what do you know? One of the easiest places to cut budgets in the healthcare practice is to go to pharmaceuticals. And so they squeeze and they squeeze and they squeeze. And we don't, typically in my experience, when we commit or they commit to us, they don't pull through at the numbers they think they're going to pull through at. And we don't have the benefit of take and pay contracts.
So, I mean, in a sense, a similar question to you, Alan, because we have panel 2 on next steps. You know, if this were to solve all of our problems, so can you talk about the experience and the you know, to what extent this has been a success? Where have you run into problems with this model? It would be really helpful.
So on one level, it's working very well. We have 1,400 participating hospitals now. We're adding, we added, I think, 4 or 5 systems in the past few months. We're 6 years old. We've delivered 200 million vials of 80 different drugs. And we've had a number of tests. We had COVID. We had drugs that overlapped with medicines that came from a Pfizer plant that was hit by a tornado. And we've had some, you know, peer-reviewed analysis that shows the model's working pretty well. But even our participating hospitals remain acutely price sensitive. And they are often reluctant to opt into a drug that might be 5 or 10 cents, you know, more on day one, even if it's an insurance policy that it's going to be there for them when there's a shortage. And there are strong incentives for hospitals to purchase through the big GPO contracts that drive volume. So it's hard for them, to Christine's point, to kind of opt out of the usual way of doing business.
So there's potentially also switching costs for hospitals to switch to someone else than the GPO.
I don't know if it's a switching cost or if it's a financial incentive to buy through the contract.
For an economist, it's the same thing. So one other question that I wanted to ask. So this is one model that has been tried. I know that other organizations have put forward other solutions. And I wonder if we could discuss them. So some of the group purchasing organizations have had programs where they can sort of provide inventory. Unfortunately, we couldn't get a representative to participate from either a wholesaler or a GPO on this panel in the short time that we had. But I'm wondering to what extent you guys have seen this and have experience with these kinds of programs, and to what extent they have moved the needle, and to what extent there's more to be done in that space.
So obviously I've experience with both, you know, one of the largest GPOs, and they have specific private label programs where they actually take over the drug supply from the manufacturer, right? You supply a certain amount of doses, you do it in their private label, and then they can allocate through shortages, et cetera, et cetera. Those programs are incredibly expensive for a manufacturer, which ultimately then gets passed on to the hospital. So I don't know that that is a solution as much as an acceleration of the non-sustainability on the manufacturing side. The wholesalers programs are newer, and I think they're also having some success. But I would say their model is actually not that much different than Alan's model. It has just a different hook, if you will. They have a different way of entering the customer, and they have different things that they can offer. But again, everyone, at some point, it comes down to a critical question, which is, are you going to pay 5 cents more for quality and predictability? That's really the question. And if you're not, it doesn't matter what model it's not ever going to work.
So this is going to be a big part of the discussion on panel 2 about how we move to that. So I will, have us not necessarily move into the solutions for that reason. I wanted to talk about another piece of this, which is, the discussion that we have had, again, is around the economics and manufacturing quality what we haven't sort of touched on more explicitly is geopolitics here, right? There's a lot of concern around potential exposure to China. The potential for COVID really made people think about the potential for export bans and to what extent they can affect our supply chains. My understanding is that in the last 20 years that we've been tracking shortages, there have not been a shortage caused by export bans, but it's a real possibility.
I would say there were limited period of time shortages during COVID, specifically around emergency room type drugs where governments were refusing to ship them. Point in time.
Yeah.
3-4 weeks at a time, not months and months and months, but yes.
Like the others. So let's talk about what can be said about efforts to try to think ahead and help us deal with those kinds of geopolitical disruptions, because there have been a number of efforts in that space to help us, in a sense, make our supply chains more reliable that have nothing to do necessarily with what we have discussed. So can we, maybe Vimla, you might be able to speak to some of those efforts in terms of understanding our geopolitical risk and whatnot.
Yeah, I'm thinking about the data, and so I guess just to set the stage for the discussion, when you're looking at generic drugs, you'll see that most API production happens in India. There is some API production in China, but it's fairly small. And then when you look on the branded side, again, thinking about API, it's Europe, some production in the US. So then back to the question of shortages. I mean, we see, geographic concentration anywhere as a predictor of shortages. And in fact, many of the shortages that we've seen, happened with production in the US. So there may be other reasons to address the geopolitical, to address the security of the U.S. pharmaceutical supply chain, but shortages historically have not been caused by geopolitical issues.
So actually two pieces. One is to what extent it's geopolitics in terms of export bans and whatnot. But another piece that I wanted to highlight that you said is that actually probably most shortages that we have experienced historically were really driven by issues in U.S. facilities. This is not foreign versus domestic of historically looking back. Moving forward, it might be a different story if we have a conflict with a country that decides to stop sending supplies to the U.S. But historically, this is not a domestic versus foreign issue, right?
I think that's fair, and I know there's a distinction between geography and geopolitics, and so having manufacturing move to low-cost environments with less regulatory oversight, and in a lot of cases, not that there aren't great manufacturers in the developing world and shoddy manufacturers in the developed world, but there are lots of examples that we know. The cancer drug, the cisplatin, carboplatin, the cisplatin shortage of last year was an example where the FDA went in and they were pouring acid on their records, right? That's a matter of public record. So that shift to poor regulatory oversight, low-wage economy puts pressure on domestic manufacturing and makes it harder for those companies to stay in. Long term, I do think we have to think about geopolitical risks, though. Some of the companies that are increasingly important in the world's medicine supply may not always be our friends.
You want to add anything to that?
I was going to say, I think that's fair, but I am still drawn back to what creates a secure supply chain, and it's redundancy and flexibility. And I don't know that I think that that's necessarily geographic, but you know what it's not? It's not one plant in North Carolina that has 90% of anything. right? It's multiple places of production. Do we have some additional comfort if those are nearshored or, in the developed world, and we can get inspectors in? For sure. And I think that we need to value cooperation with our regulatory agencies as just table stakes. If you're not going to let the inspectors in, I don't know what we're doing. We shouldn't be talking about that. But beyond that, there's a comfort in, we make everything in the U.S. and it all sits in one place. And I don't know that actually gets us to where we want to go. We need to be very thoughtful about making sure that our supply has enough buffer for redundancies, natural disasters, labor. There are lots of things that can happen even in the developed world that can be a shock to the system. All of those things probably cost money, and you do need to make space in the model for that redundancy and flexibility.
So, thinking already towards panel 2, because in a sense you're moving us there. That's okay, that's totally fine. And I think what we might do, because there's, I think, so much to be said, especially in the second panel about what we should be doing next, maybe we will probably try to, I think that's where you guys want to go as well. So maybe we'll cut this panel slightly shorter to give ourselves room for the deeper discussion there. But I would like to ask each one of you to say, to get us ready for panel 2, okay? What do you consider the most important thing that policymakers need to address? And don't just say economics. I would like to have more specificity. And you can say more than one, that's fine.
Well, for me, it's policy coordination. We really need a strategy that puts pencil to paper about the things that we find that are important. So if we want to say we never want to have a shortage of a sterile oncolytic again, then there should be set actions associated with those things. And that should include a complete review of all of the policies that we have. How does 340B play into or not play into oncolytic drug shortage? How does IRA and inflationary penalties play or not play in that space? How are we handling reimbursement for Medicare? Is that different than for Medicaid? How does commercial reimbursement? You need some people to sit in a room and really look at the whole system and develop some sort of a general roadmap, right? You're never going to be super specific, but you need to see where there's conflict in the policies that are already existing, because that may create space, right? We may be able to let a little air out of the tires. If, for example, you exempted generic drugs that are below, I don't know, $100 from 340B, I actually don't think it would make a huge impact. I'm sure some economists have looked at this, but I can't imagine it would actually make a big deal to the hospital systems. They're protective of 340B, but the money comes from the innovative side, not the generic side. So you may be able to create some space, which then you could utilize those funds in better ways, but you have to look at the whole system.
Alan.
Yeah, if we keep buying the cheapest possible product, then we will keep driving an industry that's operating on razor-thin margins to keep manufacturing in old facilities and cutting corners. And so we need to use policy to shift procurement to take into account quality maturity. We should prefer drugs that are coming from new facilities with robust quality systems over drugs that are coming from old facilities with checkered quality histories. That should be an easy one.
Yes, I completely agree with both of my panelists, and that would have been my number one choice, economics. But I'll go with something else, which is I think we need more visibility, right? Like, we don't understand, no one in the government and the government has said this, has an end-to-end view of the supply chain and where the single points of failure are. And we need to build that, and then we need to prioritize investments based on and evidence base, and so that would be my one thing.
That's great, thank you. And there will be more discussion around this, and especially, I've done a lot of work on tariffs. There's a lot of lack of visibility about where tariffs might hit and what the exposure might be. The White House is thinking about doing Section 232 analysis that will require a lot of data that I know that the government doesn't actually have direct access to because we don't have visibility into some of these pieces. So completely agree with you, Vimla, that this is hard. Okay, so we're going to wrap a little early. Thank you so much for participating. And what I will do next, what I would like to do next, oh, sorry. I have microphones here. Is one of them not working? Oh, one of them wasn't working. Okay. So, again, we spoke quite a bit about manufacturing quality challenges and that as a driver. We're going to change gears and now talk about response. Let me actually just mention one thing. So Vimla mentioned that, in a sense, a lot of the shortages are a self-inflicted wound, because what makes manufacturing quality issues and disruptions that sort of derive from that, it's not what an economist would call an exogenous shock, meaning a shock coming from outside the system, but something that really is generated by the system. What I would say is probably hurricanes are somewhat different. And this is actually why I wanted to sort of highlight why I didn't use the word resilience in the title of the talk, because there's, to me, a difference, and actually I attribute this to Steve Colville, who sort of pointed out the difference to me. There's a difference between resilience and reliability. Resilience is the ability to withstand a shock. So once a hurricane happens, once the INTAS facility shuts down production of a cancer drug, what happened? How resilient is the supply chain? And this is what Christine talked about when she mentioned, we need, backup facilities. We need to have spare inventory and so on. Reliability is both resilience, but also making sure that the shock doesn't happen in the first place, or that the shock is small, right? So now we're going to really talk about resilience, but a lot of our discussion is around that and reliability. So with that, I would like to invite over here Stephen Colvin and Laura Bray. So first, let me begin with Laura. So I actually mentioned Laura in my opening remarks. She's the mother that I spoke about. Her daughter, so what's amazing about Laura is that what she did is something that I think a lot of patients don't do. Laura said, no way. Actually, she was told that one of the drug that she was supposed to take, there was a 15-month wait for the drug. And Laura said, not over my dead body. She got on the phone. She called lawmakers. She called hospitals. She called CEOs of wholesalers. I don't even know. And she found the drug for her daughter within a couple of days. But Laura didn't stop there. She decided that this should never happen to another patient. And so she founded an organization called Angels for Change. She's actually her role in there is not the CEO. She's the chief change maker, which is exactly what she does. So she was on the front lines she will talk about the role that her organization played in this and had the insight on the patient side and the stakeholders. Stephen Colville is Assistant Research Director at Duke Margolis Institute, where he leads the Revamped Drug Supply Chain Consortium. And actually, Duke Margolis is where Stephen and I first met when I was at Duke Margolis and helped start up some of the work around supply chains. Stephen was on detail at the White House in the second part of 2024 as Senior Policy Advisor for Medical Supply Chains in the Domestic Policy Council. But this job turned out to be much more than an advisory role. He was just not in the front seat in the saline shortage, but he was there to help coordinate the response. So I will pass it on to you. Thank you.
Thanks, Marta. Good afternoon. Thanks for having us to USP and Brookings I'm excited for us to take a little bit of a deep dive into a drug shortage. And I think we should level set that Stephen is, as you see, he is an advisory board member of Angels for Change.
Wouldn't miss my badge.
Yeah, so we've worked together for years, and in his work at Duke Margolis, I am an advisory board member. We have worked together a lot. He was on leave from those roles, though, while he was working at the White House. But the shortage, I'm going to talk about the IV fluid shortage a smidge. What I think is unique about this fireside chat is we were both on front lines, but they were a little bit different front lines. And since today's event is about the role of government and drug shortages, I think we're very lucky to hear Stephen's front line and the role of government. The front line I was in was with industry and patients. We run a drug shortage hotline, the nation's only, and patients, physicians, pharmacists, anyone can call us in an active, scarce event, and we work with the supply chain to get them access. So we're going to kind of talk about the two front lines we were in during that time, and the story starts in September, actually September 28th of 2024. I know where I was. I live in Florida, so we were hunkered down for the hurricane that was passing us, and without power. But I did have cell phone service, and a hurricane went past us in Florida and then went on to North Carolina and impacted a facility there that does the majority of IV fluids for the United States. This was a pretty scary event, and 10 days, but it didn't stop there. 10 days later, the facility that does the second most IV fluid shortage was in the path of Hurricane Milton. So what we had was the facility that does 60% of our nation's IV fluids, and the facility that does 25% of our nation's IV fluids, both impacted by hurricanes within 10 days. So it was a pretty dire and severe scenario. Not something that industry on its own or a small nonprofit on its own could really handle. It needed significant collaboration and work. So in natural disasters, much like healthcare, don't keep 9-to-5 work schedules. So if you can look at your calendar, the 28th was a Saturday, I remember. I know you remember. Where were you that day?
I do. It's one of the things you definitely don't forget. So I actually had family in town that weekend. We were at the Air and Space Museum. One of the few times that I wasn't thinking about drug supply chains. That's usually what I'm thinking about. But I remember walking out of the planets exhibit, kind of pondering our place in the universe, and then boom, I get the notification around the potential severity of the hurricane damage in the North Carolina facility, and quickly scoped out a place there in the museum to do some initial go through initial status reports and situational updates, and send a status report up my leadership chain. It immediately became apparent how severe the shortage could have been. That's one of the first things we did was assess the range of potential outcomes. On the negative side of that was mind-numbing of how impactful the shortage could have been, debilitating to the health system in the country. And don't get me wrong, the shortage was very impactful, but on the spectrum of where it could have landed, I think it was pretty far on the positive side. I think that's a testament to just the whole industry and various government agencies all being catalyzed to action by this really devastating event. And when we jump together and have a common goal like that, it's really, there's a lot that we can do, and it's just gratifying to see how everyone did jump forward and put their time and effort and energy towards solving the problem, and it really made a big impact for patients as a result.
Yeah, that's true. And, so I'll give a couple of details. Stephen glossed over the jump to action, but the jump to action was 98 planes carrying 13.1 million units of IV fluid from 5 different countries into our country to be able to still satisfy this shock to our supply chain and ensure patient care. It also included 60 Mack trucks driving from, into Hurricane Milton's path to pack up all the IV fluid that was at the second facility, safeguard the facility, which they did, and then return it back, within hours after the hurricane left so that we could continue. And it's that kind of work that leads to this collaboration that you're talking about. And, the FDA said the way out of drug shortages is through collaboration, right? That's their statement. The way out is through collaboration.
Right, and
How did we use collaboration in this event?
Well, I think in terms of what went well, collaboration was one of those things. It's easy to collaborate, but it's really hard to collaborate well. And I think to collaborate well, you have to have the organizational infrastructure in place to do that, and it has to be set up in advance. So we had the HHS Supply Chain and Shortages Working Group that included representation from FDA and ASPR and CDC and many others, and was chaired by the HHS Supply Chain Coordinator. So that group was elevated and kind of expanded during the height of the shortage, but the working norms had already been worked out, and the collaborative individuals were readily identified and knew what their roles and responsibilities were going to be. I'd also just highlight the institutional knowledge was really critical. It was just fascinating to see how good these people were at their jobs at the time, and just they had gone through a lot of other shortages, whether it's infant formula or the Pfizer plant tornado or COVID. Obviously, there's been a whole host of shortages, and so the sequence of events was unclear at the very beginning, but quickly became clear once everyone's expertise came together, and FDA really moved mountains, worked day and night and weekends to evaluate well, first of all, identify alternative sources of supply and identify that there was a need for alternative sources of supply, which was pretty obvious early on. But then going through the reviews to enable temporary imports, because we were tapped out for supply in the US, so looking elsewhere for supply and finding ways to temporarily import that product, and then liaising with ASPR to make the airlifts that you mentioned come in and get product out to patients as quickly as possible, communicating with wholesalers and distributors about making that happen as well. And then one other thing I'd highlight that I thought was really impactful was working collaboratively with professional societies and just other organizations in the supply chain on things like conservation. We had limited amount of IV fluid available. We need to make sure that it gets used in a that we're good stewards of that supply, and it gets used in the most critical cases. And so just to highlight one example, ASHP, American Society for Health System Pharmacists, created conservation suggestions for hospitals and worked to enable things like determining where IV fluids might not be needed and could be saved for the most critical cases. And I think just that's an example of the industry jumping in on a solution. I think one more thing I'm going to highlight as well, evaluating the need for the Defense Production Act and getting manufacturing up and running as quickly as possible. So if there's a bottleneck in being able to ramp up manufacturing or get manufacturing restarted, the Defense Production Act was used to be able to prioritize certain types of equipment or whatnot that could help that be accomplished. So a lot of collaboration there.
I agree, and from my view, it took hundreds of, maybe thousands of people doing their jobs on nights and weekends for that to happen, right? I mean, it wasn't just this collaborative government response and advocacy response and healthcare community response. Industry, the distributors there ready at unique times to get those truckloads and get them off and into the hospitals as fast as possible. The manufacturers, the other manufacturers in the space, increasing their capacity and supply as fast as possible. 503Bs doing the same thing to figure out how we can compound onshore, and all the advocacy organizations kind of working together to figure out how do we leave no patient behind. And like, this kind of collaboration is unbelievable that we did in about 70 days. I mean, it was 70, there was no weekends, there was no, hey, I'm going to a movie, guys, right? We're all emailing all hours of the night trying to figure out how we're going to do this. And one thing I think about when we talk about doing collaboration well is how good we are in an obvious catalytic crisis. But one thing that keeps me up at night is, how can we be that good when we don't have this obvious catalyst? Like, how can we take that response and, move it into steady state? That's what I want. I want that kind, not that 24-hour, 72 days. I want that kind of collaboration in steady state. So talk to me about your thoughts.
Well, I think in terms of things we could do better in the future, that's the number one thing that comes to mind for me, is taking a proactive, preventive approach, which actually Christine mentioned in the first panel around, we need a strategic plan that identifies what are the outcomes that we want, what are the objectives, and who's responsible for achieving those objectives. Like, we need that strategic plan. And I mentioned the HHS Supply Chain and Shortages Working Group previously that was chaired by the HHS Supply Chain Coordinator. That coordinator published in January the first ever draft strategic plan around addressing drug shortages. And I just think progressing that sort of initiative in the future is really critical. And there's still a lot of work that need to be done. There's a lot of different ways it could be implemented, and I think we need to figure that out, how that happens. But an example of something that could be done in the future to improve on future strategic planning efforts is things like being more specific with the objectives that we want. And that can help get to the catalysts that you mentioned. So let's not say things like, our goal is to improve supply chain resilience. That doesn't catalyze anyone to action. We need something like, let's reduce the number of new drug shortages from whatever the numbers are, 80 down to 40 or something like that. Let's reduce the duration of shortages from 4 years to 1 year by a certain time frame. Like, that's the kind of objective that we need, and we need a strategic planning initiative to make that happen.
Yeah, the outcome measures are key, right? That's what we need. The emergency of life and death, like, we know what the outcome measure is during this crisis, right? If I don't get this medicine into the hospital, patients will be harmed significantly. And I think that is what's missing in our proactive work, is those very specific outcomes that we know we all need. I also think in the previous panel, they talked about single points of failure, we need to fix that, right? I joke and say, 6 Sigma, this is 1 Sigma, but that's a nerd business professor response, so if you don't know, but we do not even have 2 levels of failure in this life and death supply chain. Sometimes we have 1 level of failure. And so, but I do think maybe, can we talk about points of accountability? Like, maybe we do need, along with specific outcome measures, like single points of accountability. Who is leading the way, with this subject matter expertise, not just reactively, but proactively.
You did get, I think, a couple laughs from your 6 Sigma.
Thank you. Thank you for the couple of Sigma nerds.
But
Risk management nerds.
Yes, I do think we need the single point of accountability that you mentioned. That doesn't mean that entity would do everything, but they're the lead for it and can answer for why are we achieving or not achieving objectives. I think we also just need to see what we can, how do we get manufacturers and everyone in the supply chain, GPOs, wholesalers, health systems, to be jumping over themselves to see who can be more resilient, get competition on resilience. Like right now, we're jumping over ourselves to see who can be cheaper, which is important, but we need that resilience and reliability component of competition too. And I think that also gets us some comments from the first panel around, it starts with looking how the money flows through the supply chain, and that first step, the payment from CMS to healthcare providers, from Medicare, and also from payers to healthcare providers. Like, let's make sure that enables those that are resilient to be more successful. And I'm treading into panel 2 talk here, so I'll just leave it at that.
We'll cut you off. But some specifics about this shortage that we can give to lay out the scenario so we don't get into solving, panel 2. But, this, we talked about there being one facility in one place in the U.S. that did 60%. And another facility that did 25%. And when we're talking about that, a couple of pieces of the supply chain is a significant 60% of providers who purchased from the largest manufacturer were purchasing 100% of their supply there. So not only were we as a nation not really resilient in our ability to recover, but individually, a lot of people were putting all their eggs in one basket, and that one basket was putting all of their eggs in that one location. And so getting to the fact that it's not just lots of facilities, but maybe it's multi-sourcing and, having some buffer supply, as we look towards building that resiliency.
I think healthcare entities do that because that's the best thing for them. They care deeply about giving good patient care, but also it's the best, in many cases, it's the best thing financially for them. So I think we just need to think proactively and preventively of how do we change that paradigm so that being more resilient is actually the best thing for healthcare entities.
A unique thing about this one also is that there were 4 to 5 manufacturers of these medicines. It's just, 3 manufacturers were carrying a very little amount of supply. But there also were hospitals that had multi-sourced with everyone except for the major supplier, and those hospitals didn't have or feel any impact. They were still receiving all of their supply through this national crisis, and their patients were seeing no impact. So, I also think one thing that when we do have multiple providers or multiple manufacturers, using them, I think, that's what I saw in these moments. When things were the most dire, we were reaching out to the hospitals that did have buffer supply and multiple sources and asking them, will you share with this place in dire need? And they did. And so those hospitals were paying more for a decade, right? And doing everything for their patients. And then they were also sharing to others. And so remembering that didn't come free from, so like that's one thing to share about this one as a potential thing we could do a little bit better.
Right, so you mentioned, a lot of things you mentioned were private sector related around multi-sourcing and buffer stock. I think I also want to hit on some things from a government perspective that we could do better. I think another thing that comes to mind for me there is around data. Like there's a wealth of data, supply chain data. Could it be improved? Absolutely. But there is a wealth of data already available at HHS and elsewhere around supply chains. That doesn't necessarily mean that data is easily translated into insights that can lead to better decisions. So, data, insights, and decisions. We need that progression more often, data, insights, decisions. So to give to contextualize that a little bit, I think in this specific shortage, everyone knew that there were large volume IV fluids in shortage. I think everyone in the industry also knew that that would lead to spillover effects and shortages potentially of other products like premixes or certain types of syringes or small volume IV bags. Everyone knew that was likely to happen, but I don't think anyone knew which products is it going to go to, how much is it going to go to a particular product, when is it going to happen, when is that going to cause a shortage. So is there a data source like the supply chain control tower within HHS that has a wealth of data from wholesalers and distributors on inventory coming in and out of the wholesalers and distributors and inventory levels that could be used to inform better decisions? Like, you know, if you're a data person, you start salivating when I talk about things like automated reports and, you know, notifications and alerts and all that could get sent out to people that need it to make decisions around, you know, you could imagine a lot of things at FDA, decisions that could be made around drug shortage lists or prioritization of reviews for temporary imports or other sort of reviews, and ASPR with their response capabilities as well, the strategic national stockpile and other things. There's like so many use cases. So that's just one example where I think there needs to be a data strategy as a component of that larger strategic plan that we mentioned previously. And actually we haven't mentioned yet that there was, many of you probably saw the GAO report from yesterday, the Government Accountability Office report that basically reiterated what I'm talking about around the need for HHS to identify a mechanism for coordinating and putting a strategic plan in place. And that's just a really critical initiative for a lot of reasons that we've talked about.
Well, and because this is, a panel is about the role of government, it is the kind of role that, you know, subject matter experts, you know, in one place, you know, makes a good case for that role. I certainly know that I, at Angels for Change, could help answer phone calls that were coming in to me to make sure nobody was left behind, but I couldn't bring 98 planes into the United States with 13.1 million units, right? And so so, you know, it does take that, you know, important work, both reactively and proactively, and the partnership with industry and advocacy.
Right, and the people who really know what they're doing and have done it before, it makes it so much easier to, I mean, it was, yeah, the expertise of people is very apparent. But Laura, I want to ask you a question as well.
Sure.
So you actually, you obviously saw a lot of patient experiences during this shortage and how they were impacted at different care sites or based on different products that they were needing. I'm just wondering if you could speak to, like, did you see differences in care
we always see differences in care, and I believe that if, you know, someone other than me were answering these calls, we'd probably have the sense of urgency to make all of this go away, because they're quite difficult and soul-searchingly, you know, difficult to take. But absolutely, what did we see? What's unique about IV fluids is it isn't just a hospital medicine, right? There are people in this country who need IV fluids every day to survive outside of a hospital setting, and their supply chain is drastically different than a hospital supply chain. And what we saw was a dramatic disparity in communication and collaboration and work in that space. I am thankful that we were able to work and figure those things out, and obviously your role, you know, you helped a lot because there was a lot of different supply chain members there. But definitely, I believe that the shock to this system disparately harmed patients who were in need on a daily basis of PN, TPN, and EN for their care. And we need to be factoring other patient populations outside of hospital in our response at the very, you know, proactively, but also during a crisis. So thanks for asking. It is true, we did see disparate treatment. Well, so, you know, the next, we have 13, we're right on time, we have 13 seconds. So the next one is building resilience in the supply chain. I hope we teed you up real well, and we're looking forward to that next panel to talk about some solutions to these reactive and proactive challenges. So thank you.
Thank you.
Okay, hello. I'm going to start us off as people get seated. We are the long-awaited panel 2. If I had known the anticipation would build, I would have made T-shirts. I'm Kristen Link-Young. I am a visiting fellow at Brookings and the former deputy director of the Domestic Policy Council in the Biden White House, where I led health policy for the 4 years of the Biden administration. I think you all got to see how lucky I was to have hired Stephen to join me on the team there and the incredible work that he did alongside our amazing agency partners at HHS and in other parts of the White House as well. So I'll quickly introduce our panelists. Eric Edwards is the founder and CEO of Flow Corporation, a pharmaceutical manufacturer focused on securing the supply chain and through a US-based advanced development manufacturing approach. He also has a background as an inventor and a researcher. Meryl Tufanian is a senior vice president of regulatory strategy and government affairs at Amneal Pharmaceuticals, another US-based manufacturer of generics and biosimilars. And Meryl joined Amneal from FDA, where she held a number of leadership roles, including as director of the Office of Generic Drug Policy. And finally, Marta Wyszynska is an economist and senior fellow at Brookings with me, and Marta, as you have seen today, has deep expertise and enthusiasm for prescription drug supply chains, having worked on the topic since 2011 when she served at FDA. So let's dive in. Obviously, we were just talking about natural disasters as a source of supply chain disruption, but as we heard earlier today, there are many different causes of disruption in supply chains. And one thing that folks might have on their mind this week is tariffs. So why don't we start there? Marta, can you talk a little bit about how tariffs might be expected to impact this very fragile market and some of the thinking that you think is going on inside industry and inside government as well?
How much time do I have? You know, what's really interesting about tariffs is that they are both a policy solution, but also a potential shock to the system. And so let me first talk about the role that tariffs play in reorganizing markets, so you can sort of see how those two play out. So a tariff is basically a tax on a foreign manufacturer, right? So as the foreign product comes through the border, there's a tax applied to it, which is the tariff. That makes that product more expensive, and it shifts demand away from the foreign manufacturer towards a domestic manufacturer. That domestic manufacturer can now increase its market share. That domestic manufacturer might also be able to increase its price. All of these things make making production in the United States more profitable. The domestic manufacturer will increase production, increase their sort of footprint, and it will encourage other manufacturers to enter the market. So that's the premise, is to basically, in a sense, shift the weight from the foreign manufacturers towards the domestic manufacturers. And as a weight, it is actually a tool. So I'll give you an example where I thought that tariffs were applied in a particularly smart way. So sort of, again, look at the kind of economics to it. Number one, it helps if you have domestic manufacturers, right? Number two, you have to have the ability also, it's not just about shifting necessarily market share, but it really is important that the manufacturers are expecting that their profits are going to go up, right? And so overall profits go up, especially that it costs money to expand production and it takes time to expand production, right? So where you are going to see tariffs be able to turn on and be quite effective is if you already have domestic manufacturing in the United States, and also if the cost of increasing domestic manufacturing is both low and fast. So one good example of where I think a policy like this was applied where it made a lot of sense are syringes. So I think it was perhaps last year, I don't know how many of you had seen the news around FDA issuing guidance that You should be concerned about the quality of syringes from China. Not just one manufacturer, but just across the board. And if you think about sort of the importance of syringes, I actually did an analysis that looked at the share of inpatients taking drugs that come in vials. When you go to a hospital and you get a drug, a sterile injectable drug, it's basically 90%. So syringes have massive footprints because having a drug in a vial is not gonna get you very far if you can't then put it into a syringe, right? So huge footprint. But it's also a very simple, low-cost supply chain because it doesn't have multiple steps, and you can probably turn on production with far fewer sort of barriers to entry and sort of much faster. So that's sort of an example of where a tariff, and we also had a domestic manufacturer. We had some leave, and we had a domestic manufacturer that could be propped up. So that's sort of where a tariff can work really well. Where it can become a shock is when the manufacturers that are foreign potentially cannot increase their prices because the buyers will not take it. Domestic manufacturers cannot expand their production fast enough, and we have a gap. And at that point, a tariff can become a shock to the system. So I just recently put out a paper where I, in great detail, walk through exactly how all of this works out. And what I wanted to point out is that I would group drugs and the impact that you might see into three categories: branded drugs, generic sterile injectables. I guess you're not going to be surprised after hearing panel one, right? Generic sterile injectables and solid oral dose generics that you see in the pharmacy. And the reason why I sort of differentiate those three is because there are three different things that matter. One is the exposure to tariffs and to what extent there's reliance on foreign manufacturers. But what really matters is the ability to pass on the price increase of the manufacturer and the ability of the manufacturer to absorb whatever they're not able to pass on. And then on top of that, the resilience of the supply chain. So working backwards, which supply chains are not resilient? From panel one, generic sterile injectables. Okay, so we know that. We talked plenty about the challenges that manufacturers have with increasing prices, both because of contracts that exist, but also because of government programs like Medicaid inflation rebate, and especially the footprint of the 340B program. So here, if you increase the price by more than the consumer price index, let's say there's a 25% tariff, if you increase the price by more than consumer price index, which might be 5%, then you have to pay back the 20% to Medicaid, if you're a generic injectable, to Medicaid, but more importantly to anybody who is in the 340B program. For a generic manufacturer making, I don't know, carboplatin or cisplatin, where it's an outpatient drug, I wouldn't be surprised if half your sales come from 340B. So you might have to pay it back to that, basically not be able to pass on to that part of the market. So that's another place. And then another place is the margins, right? So for a branded manufacturer, their margins are really high, even if they're not able to pass it on. And they also face Medicare inflation rebates, which most generics don't face. Their ability to absorb that tariff is significantly higher. When you have a very small margin and you cannot pass on that tariff, you have two choices. One is cut cost. And cutting cost in this environment, we talked about this. There's not much room to go if you start doing this, especially with all the cuts at the FDA. I personally worry that FDA's oversight is not going to increase, but is going to decrease, given what's happening. So I worry about that part. And I also worry that a lot of manufacturers will say, I can't make money in this. But what's interesting in this setting, normally we have not seen exits be the trigger for shortages because a manufacturer doesn't want to be blamed for a shortage. So when they're not making money on a product that's essential, that's a cancer drug, what they will do is they will scale down production until their market share is a couple of percentage points. And at that point, they're not going to cause a problem this time around. They'll just make the supply chain less resilient next time around. Now, I do think that the game might change. Now it's not their fault. Now the threshold for exiting the market might be higher, and there might be more correlated exits. So we only have tariffs right now on products coming from China. We don't have, where I am going to start getting worried is when the tariffs get put on Europe and on India. So as you might know, there has been a delay in the announcement. The tariffs are now, right now, pharmaceuticals are exempt from tariffs. So what I am looking for in particular is to what extent how generic sterile injectables are going to be handled in the announcement. And frankly, you know, if you read my paper, which then gets us to the rest of the session, tariffs are not going to lead to onshoring of generic drugs. So for us to onshore generic drug production to the United States, we will need to deploy in a lot of other tools. So I guess what I will be looking for is how generic sterile injectables are sort of managed in this context, but also what other tools will the administration put forward to help us onshore these supply chains?
And
How
so I
much
think-
time? Okay, I think that was, hopefully that was, yes. And
That's
this
a
is
great start, and I think that's
Exactly.
actually a great segue, Eric, to you. Flo is making major investments in U.S. manufacturing, some of it supported directly with federal dollars. Can you talk a little bit about that experience, where it started, how it's going, what you're thinking about these days?
Yeah, sure. So first of all, thank you all so much for being here, and thank you for those who are joining us online. And I mean, we could have a half a day session on all of these topics. So Flow Corporation's mission is to help bring medicines to life through advanced development and manufacturing in America. And our focus is on small molecule active pharmaceutical ingredients, the ingredients that are critical that go into many of these generic drug products. But I'll take it one step further because it hasn't been discussed today. We believe in a global pharmaceutical supply chain, but we also believe in pharmaceutical sovereignty for the most critical and essential medicines that are necessary to sustain the health of the American public. So we believe that there is a portfolio of critical essential drugs that our warfighters need on the battlefield in case of military readiness, because 27% of those drugs and those active ingredients come from Chinese manufactured components, and a significant proportion of critical essential medicines for which there is no therapeutic alternative, which you need in order to live, that must be available on U.S. soil. And it is with that mission and that focus that we were blessed and fortunate to be partnering with the United States government back in right at the beginning of the pandemic, 2020, early 2020. We began work with HHS, ASPR, and BARDA initially as a contract to try and re-secure our nation's pharmaceutical supply chain, beginning with these critical active pharmaceutical ingredients. At that time, it was a list driven off of COVID, to build development, CGMP manufacturing, and then critical storage capabilities, standing up the nation's first strategic active pharmaceutical ingredient reserve. And the idea was if we could start making investments and start working together in a public-private partnership model and really try to bring some of this critical infrastructure back on U.S. soil, we can begin to protect our supply chain from future shocks, especially for a select number of critical drugs. So that was 5 years ago. We are really, really excited at how far things have advanced. So our development capabilities are now built. The analytical capabilities are now built. We are now, we have 2 fully operational CGMP manufacturing facilities. Our first validation campaigns just completed for our first API. We filed 4 drug master files. The Strategic Active Pharmaceutical Ingredient Reserve Program is now operational. And we're making medicines on U.S. soil that have not been made here in 40 years. And that's exciting. Our first validation campaign was for epinephrine, from which the majority of America's supply comes from Taiwan. And so I guess the question for this audience and for those who are listening in is, what medicine should be made on U.S. soil? And what role should the government play in helping to support? I will tell you all, we're not competing with Chinese companies or with Indian companies. We're competing with their governments who really have mastered the long-term play and strategy and have executed really amazing public-private partnerships in order to invest in their own industries. Earlier, it was mentioned that China has a small proportion of active pharmaceutical ingredient manufacturing, but what wasn't mentioned is the number of drug master files that China is filing is growing by 60% year over year. And the majority of the Indian-based active pharmaceutical ingredients come with Chinese-based components and key starting materials. Or you might have 2, 3, or 4 steps that begin in China, and India does the penultimate step and then ships it over here. So how much of our drug supply chain should we have on US soil? And I would submit to you, it's impossible to have all of it. But there's a set number that we need to ensure in case of that next natural disaster, public health emergency, war, or trade dispute, that we're able to have resiliency just in case. So that is the FLOW program with the government, and we are making progress, but so much more needs to be done. And obviously we have ideas on where, what policies need to occur to make that happen.
Thanks for that. Meryl, I'd love to bring in your perspective as a larger manufacturer and the work that you are doing to make investments in resiliency. What have you been working on in this space, and how do you see the government as addressing the obstacles to making the kinds of investments that are needed here?
Yeah, thank you. And again, thanks to USP and Brookings for this sort of vital opportunity. Sort of taking a step back, I want to acknowledge what we have all recognized over is the complexity and how there is not one tool that will be the surefire answer. In this context, when you think about sort of what will incentivize my company, and my company has a big domestic manufacturing footprint and a very big manufacturing footprint in India. We have a facility in Ireland, and there are a number of similarly situated essential medicine, generic manufacturers who not only have a global presence, want a global presence, and are willing to commit to a global presence. And I think, partnerships like with FLOW is a direct, calibrated, targeted way to, but is limited. I would love for it to be, it's more expansive, but I think that reality is that we need additional tools in the toolkit, partnership in the government, and recognizing that the generic drug industry is we alone have over 260 FDA-approved products. We, every single day, are mastering the efficiency of the supply chain. And what I think, having sort of been a regulator up at White Oak and now in real life, is, yes, things that will incentivize domestic manufacturing, will incentivize resilience, will incentivize quality from the get-go perspective is important. But if you create a market, if you create a market-based incentives in which very active manufacturers from across the globe can participate in, that's where you're going to get the sustained reliability. And those, were talked about. I appreciated the sneak peeks in the first couple of panels. Stephen mentioned the fact that competition is really where you get that absolute efficiency, but there's got to be a mechanism to create that market. And that market means manufacturers have to get paid more than it costs to make it. And right now, we're not. And we certainly can't do that in a resilient way. And you're going to have manufacturers like Amneal, who is deeply committed to a quality culture. Marta, to your point, if we're going to consider, are we going to cut quality, or are we going to step away from the market? A company like Amneal is going to step away from the market. So what do those market-based incentives look like? We can talk about reimbursement. We can talk about prioritization for quality manufacturers by U.S. government purchasing. There could be incentives not only for a direct reimbursement incentive for resilient pharmaceutical manufacturers, but there could be rewards to hospitals that then could be calibrated back to manufacturers to inject in the right moments in the system. Some people in this room have heard me say this a couple times. If we build it, they won't come. But if you build a market, you better be sure we're going to show up and try to participate in it. And I think we've seen a lot. The good news is we've seen I think a real sea change even in the 2.5 years that I've been thinking more critically about these. It used to be an anathema to talk about any higher drug price, for good reason, because I think there's really important conversations going on about high drug prices. But over the past, I would say 18 months to 2 years, there's been a significant shift when we've been talking to policymakers across administrations, across, sides of the aisles in the Senate and the House, that there's a recognition that there is too low a price. And I think last year, I feel like all of our years have sort of compressed. There was a really remarkable bipartisan proposal from the Senate Finance Committee that really joined issue on the reality of the market and what some of those market-based solutions could be. They're very complex. They're very different for Part D versus Part B. But that complexity shouldn't have us shy away from looking for real solutions.
Yeah, thanks for that. I mean, fundamentally, we are talking about how we create incentives throughout our system so that hospitals want to pay 5 cents more for that vial. What do we do with our federal policy tools and other policy tools to make hospitals pay 5 cents more? So Marta, can you talk a little bit about where you think things stand with the Hill right now, and how you feel like our demand side policy conversation is going these days?
So one thing that I wanted to sort of highlight, and maybe I can actually kick a question back to Eric and then come back. So if you think about, going back to this discussion around tariffs, right? It's one, do you want to be making product in the United States rather than moving all of your production outside of the United States? It's one thing if you have facilities here and whether you want to shift back. It's a whole different thing to bring it back to the United States. So it costs over $1 billion to make a sterile injectable facility. It can be more. It takes 3 to 5 years to make it. We're talking about, so even if we were to be increasing, the margins, we were talking about a cancer drug that costs $10, and the margin is, I don't even know whether it's like $1 or $2 on some of these products. So, for us to be thinking, so there's two pieces. One is, how do we even think about investment in the United States? And another one is, how do we sustain the investment that's made here? So if you don't mind, I would like to come back to Eric, because I feel like it would be a missed opportunity. Because Eric is sort of an interesting case, Flo is an interesting case, where the government actually said, we're going to help you build that facility. And then we will come back to now, okay, how do you live in that once you have the facility? So can you talk a little bit about the role of the government in supporting Flo's, sort of facilities and the infrastructure, and sort of lessons learned from that? And then I'll come back to, okay, now you're on the market, how do we keep you here so that you don't run away?
Yeah, so I would tell you that our government partnership has been phenomenal to get us going, and it's been sustained to get us to the point of operations. Through multiple administrations, through a pandemic, and on the other side of a pandemic, now with ASPR and the Industrial Base Management Supply Chain and Program Office, they truly understand the need and the criticality of having an active pharmaceutical ingredient supply chain on U.S. soil for these medicines. The challenges and the constraints associated with working with the government in general is that there's a lot of uncertainty, and there's a lack of predictability. In the case of the Department of Defense, for example, if Lockheed is building an F-35 and they start the development of that F-35, there is absolute certainty that they're going to purchase that F-35 on the other end. When it comes to building manufacturing and medicine manufacturing infrastructure, today in America, our federal supply schedule doesn't even have prioritization over US-based drugs. So the Department of Defense, Indian Health, Coast Guard, they will focus on finished drug products that are made in the US, but if there's a US-made drug that has US-based ingredients in that drug, there's no clear prioritization right now for procurement. So I think one thing that companies need, they need sustained investment, they need certainty, and they need to make sure they work with the government on the right models whereby you can also stand up commercial sustainability leveraging that infrastructure. So for us, that has meant building out a contract development and manufacturing organization that serves the government to help secure the essential medicine supply chain and critical medical countermeasures for the warfighter through the DoD JPEO CBRN division. And it also means then leveraging that to then help pharma companies who are then wishing to use advanced development and manufacturing technologies to bring back their own supply chains where they might be innovator drugs that have higher margins. So that's been a business model perspective. The long-term sustainable funding and the certainty or the long-term investment or the policies that enable that, such as what we saw with the Senate Finance Committee, that's huge for companies like us. I think also there's a lot of challenges as it relates, and Stephen said it earlier, the coordination and collaboration between entities within the government is huge for a company like us. So we want HHS, we want ASPR, we want BARDA, we want the DoD talking to each other, talking to CMS, and coordinating policies, coordinating how a public-private partnership would work to help sustain companies who are making investments on U.S. soil to make generic drugs that have a failed pharmacoeconomic sustainable. So that coordination collaboration needs to take place as well. For us at Flow, we have been very successful in trying to adapt our model and raise private capital on top of the government capital in order to support pharmaceutical companies in the future. But you know, I'd be lying if I didn't say we don't know from one administration to the next is onshoring and drug shortages and American medicine manufacturing going to be important. We just don't have that long-term certainty.
So, Marta, let's talk about sort of where things stand on the Hill and where this conversation may be headed in the medium term.
Sounds great. So, you know, what's interesting is in 2011, when we had this major crisis around drug shortages, I think we had 251 shortages during 1 year. The government, the Hill was very engaged, the White House was very engaged, there was legislation passed, but the feeling was that we just need to give FDA more heads up about this issue, manufacturers are going to fix these problems and this will go away. And I think there's, what has changed is that now Congress is recognizing that this is, you know, what Christine said, this is an economic problem. We've got to change how, and in particular in the generics injectable space, we cannot have a system where hospitals buy purely on price. We need to change how they buy, and we need to change in the direction that they also consider reliability of supply. Easy to say, really hard to do. Okay, so let me tell you sort of where we are with this. And there's been a number of proposals. There is a bipartisan legislation on this in Senate Finance. There was a report from HHS with support from the White House that also had some proposals. So let me sort of characterize this, this space. So again, the idea is to change the weight that hospitals place on reliability. So it's not just price. And the question is, how do you do it? And in a sense, there's sort of two ways to do it. One is to basically say, if you do X, we will pay you more. And the X, sort of the behaviors that hospitals would have to place is, one way to do this is, let's figure out who is more reliable, and we'll just basically say, here's a list of the manufacturers who are more reliable, and then if you buy from them, we'll pay you more. Another way to do this, which is more what Senate Finance has gone through, is they said, okay, if you sign long-term contracts, if you don't have these kinds of price clauses, if you sort of take steps that seem to move us into more resilient sort of a supply chain, you know, we will pay more for that. What's hard in both settings, on the first setting, what's hard is we need to figure out which manufacturers are more reliable, and that's hard. And also there's a whole fight about who should figure that out, and I think a lot of people in Congress have said, we don't want FDA to be figuring this out, so that's sort of a political challenge. The other piece is also complex. You know, the Senate Finance bill, I think, was widely, I think there was a lot of excitement from a lot of stakeholders. that this is, the first major step in the right direction, but it's a very complicated bill that just perhaps would not really get us where we are. So a lot of details that need to be worked through. There's sort of another alternative of how to do this is not to even do, if you do X, then we'll pay you. It's more, let's just see, you're signing these long-term contracts. Let's see whether the hospital actually gets the drug. If they do, you figure it out how you do this. But if the hospital gets the drug, so basically pay on outcomes, right? The hospital gets the drug, you pay the payment, they ended up not getting the drug. Well, maybe you should think about who to sign contracts with, or maybe have higher inventory level. So let the system figure it out, let the stakeholders figure it out, rather than the government have the actual solution. So where we are now, and I actually had an opportunity to speak with, so we were going to have Connor Sheahy from Senate Finance on this panel, but unfortunately he wasn't able to make it, but I had a chance to speak with him. And so what he said is, number one, Congress is going to be, right now is absolutely sort of, the thing on their mind is reconciliation. Nothing is going to happen until reconciliation goes through. But what he said is that this is a bipartisan issue. There is interest on the Hill in this issue. And what he was very much encouraging stakeholders is to say, help us get this Senate finance bill into something that I think everybody could embrace. So there's a lot of work to be done, but he was very much encouraging that, sort of, where do we go from here now that we have signaled that we really want to change how the system works? Another thing that he said, and this has nothing to do actually with Congress and more about engagement with the administration, he was very much encouraging that stakeholders make sure that they engage with CMS, with the White House, with HHS, with FDA, and emphasize how important this issue is and make it a priority. And anyway, those are the words from Connor.
Thank you. And I would just add to that the importance of the openness to having those conversations. And I will say that the current administration has been very open and very curious and thoughtful and strategic about making sure that they're educated about a very, we've done this for years. Some of these folks haven't been doing it for as long, but they very quickly have come on to say, this is actually different and important for American patients. So I would want to acknowledge that and encourage folks, stakeholders in the system to, raise these issues. I think one of the things we haven't talked about, although obviously I'm looking for Laura, I can't see her right now, but there she is, hi, is sort of the importance of hearing from multiple voices that are impactful to policymakers about this issue. We all are also patients, and we have children who are patients who need these medicines. And I would say there's an opportunity to activate voices who impact policymakers, voters, additional public advocacy organizations, folks that are on the front line, but also folks who, there's a myriad of healthcare system organizations and patient advocacy groups who I think, might be very interested in chiming in on the value of this and the challenges of it, as long as that educational piece is coming through. So I would say if there's one ask today is make sure that we amplify the reality and the situation. And I'm not being overdramatic when I say the dire, circumstances, so that multiple voices are talking about the continued importance of this.
Can I, go ahead.
I was just saying, I think it's a huge point because I don't think the vast American public knows that 90% of prescriptions are generic, that the vast majority of the active ingredients coming out of those medicines are coming outside the United States of America with starting materials that feed into the active ingredients coming from China. I just don't think the American public knows that. And so I'm not trying to raise alarm bells on that, but you couple that with the fact that I'm not sure that they know that we've had drug shortages that have been profound, over 100 sustained for years and years and years, and they haven't been solved, and we're just one step away from another pediatric cancer shortage where a pediatric hematologist oncologist has to look at a parent and decide which one gets their chemo. I don't think the vast American public knows that. So I think in order to mobilize you have to raise awareness first, and then they have to have a voice, to your point, in making change happen. And I think they have been missing in some part from the conversation.
So I want to put in an important caveat here. I really think that, Congress and the administration, it's politicians respond to stakeholders raising issues, right? And this is one where you have bipartisan support. Where I am nervous is the fact that the different stakeholders that are speaking to policymakers have their own perspective, and they like certain proposals much more than others. And there's a lot of redirecting the policymakers into, oh, here's a solution, when it's totally a Band-Aid, and it actually doesn't get at the issue. And then there are issues where it's a third rail and you can't touch it, and I will have to call this out. So when the Senate Finance proposal, and I testified right before the Senate Finance put its proposal, the Senate Finance proposal had two elements, and I also had it in my testimony. One is, how do we get hospitals to pay more for reliability? And then there was another component. It was, we have to do something about Medicaid inflation rebates and the 340B spillover. And the reason why that's critical is the whole idea. So again, CMS can pay hospitals. They don't pay manufacturers. The idea is to pay more to a hospital so that hospital passes it through to the manufacturer so that the manufacturer can invest in that quality. But what Medicaid inflation rebates and 340B do? If the manufacturer were to try to pass on that price, they have to pay it back to that hospital. Then the whole thing falls apart. It's pointless. There's no point in paying a hospital more for reliability if there's no pass through to the manufacturer. When I testified on this topic in Senate Finance, the 340B lobby blanketed the Hill, saying, don't touch 340B. When you look at tariffs and my paper on tariffs, the same thing happens here. Where I really worry about shortages is generic sterile injectable drugs that have a high 340B exposure, because they will not be able to pass on the cost, and those are the ones that are going to be at a higher risk. And so I recently spoke to a group of hospitals, and I basically said, I am really hoping that those drugs are going to be exempt from tariffs. But if they're not, you will have a tough decision to make. You can either defend 340B and Medicaid inflation rebates, or you can be saying, you know what, maybe we should forgo this because we don't want shortages. So I'll just sort of, going back, it's important to have a lot of voices, but we need to agree to really which things are going to move the needle and make a difference.
So we are running short on time here. So maybe to wrap us up, I would love if you all could reflect a little bit on how you think this policy conversation has changed over the last 5 years, and what lessons that has for you. So maybe Eric, let's start with you.
I think there is increasing awareness within the government of the challenges and complexities around our supply chain. Certainly, there have been lessons learned following the pandemic, and the right individuals are realizing that gaps need to be filled, and we need to do something about this. One thing that hasn't been discussed today that I think is really important for everyone to hear, even for small businesses like ourselves who are trying to bring back the supply chain, we have to work with the government effectively in order to ensure that supply chain is brought back in a secure, high-quality fashion. So you have to have a strong FDA that is well-staffed and invested in. You must have that in order to ensure that our supply chain supporting the American public is the most secure and safe in the world and of the highest quality. And moreover, for companies like Flow that is trying to focus on advanced development and advanced manufacturing technology so that we can level the playing field and try to build cost-competitive API on US soil once again, driven by technology, you need to have a strong FDA to support innovation. So that wasn't mentioned, but for me, it's about those policies to incentivize the right level of onshoring with the right innovation, and I think there's more awareness than ever before.
Thank you. I think what I mentioned previously is really where I think that evolution has happened, and that people are actually talking about the real problem now. And I think that it is incredibly complex. There's a number of factors. It could be derailed. And I do think that there is a continued commitment by members and by both the past and current administration to realizing this is hard. We're going to have to roll up our sleeves. I will say it is an extraordinary opportunity. It's going to take courage. It's going to take an acknowledgement that we're talking more like price isn't the only, the answer. But if this generation and this moment can actually solve the drug shortage problem by creating a sustainable incentive to address the issues in almost, even in the national, like the tornado situation, we're still talking about create stability so that we are reliant. That would be an extraordinary, legacy for the policymakers to be able to say that they had the courage and the thoughtfulness, and they rolled up their sleeves and look, American people, this is what we have. Don't worry about your kids. My kid, not being able to get its medicine. I mean, we are at a moment, and I'm sort of imploring folks to rise to that moment.
I think we all agree here that there's been a sea change in terms of the understanding of policymakers that it is about economics. This is an economic issue, and we need to be sort of thinking about economic incentives in that context. And what's also interesting, so thinking about the payment programs, and I see it actually on both sides of the aisle. I think saying that the markets are not functioning properly, prices can't adjust, I think that's been sort of more of a Republican stance. But what was really interesting, seeing the HHS report, an acknowledgement that this is an economic issue, to me was actually really important, because this was a Democratic administration saying, we do have an economic incentive problem here. So I thought that was really big. So we really have gotten so far. I mean, I was really excited about seeing that. I was really excited about seeing the Senate Finance Bill. We have a lot of work to do. One thing that I'll say, something else that we have to grapple with and get to, and I think this will require, again, support from stakeholders, but also taxpayers for that matter. If we want resilience, if we want to have reliable supply chains, we'll have to pay for it. There is no free lunch. And so I think one is to have ideas, but one of the obstacles that we'll have with the Senate Finance Bill, it's not going to be free, right? If we were to eliminate Medicaid inflation rebates for generic sterile injectable drugs, it's not a lot of money, but still, the CBO will score it as a cost. So I think our next challenge is going to be how much, sort of asking ourselves and asking policymakers, how much are we willing to pay for having reliable supply chains? Building flow, that was taxpayer money, right? Helping to support that. That will require government investment. Even with the Senate Finance Bill, it was Medicare trying to prop it up, but ultimately it gets passed through to us either through insurance premiums, through higher prices, or for that matter, through higher taxes. But again, there is no free lunch here, so just something to keep in mind.
I think that's absolutely right, and it's clear that there is really incredible work going on this topic across the country in advocacy organizations and industry groups, on the Hill, the tremendous public servants inside HHS who are doing really amazing work on these issues, who I think deserve all of our thanks. And I think that's a good place to wrap us up. So if you'll join me in thanking our panelists and thanking USP for this beautiful space. Thanks, everyone.
Do a couple of closing remarks. So again, with that, I would like to conclude the program. I would like to thank for all of you who participated, who listened in online. There is going to be, this webcast is going to be saved. You'll be able to see it on the Brookings website. We'll follow up with a link as well as a link to the Brookings portfolio on drug supply chain resilience issues. We have done a number of papers in this space. So again, extremely appreciative to USP for hosting us in this great location. And I would also like to thank all the Brookings staff who helped out with the event, and most definitely to all of the panelists who shared with you their expertise and insights on this topic. So thank you so much again for participating.